tonight. I'm going to speak a little bit about medullary bone augmentation for geriatric humeral nonunions. If you don't know where you are, you're on an IlluminOss training call. So this is a talk sponsored by IlluminOss. So we'll get into some of the utilization of that device and kind of where I've seen it grow and develop in my practice. So just to start, non-biologic medullary solutions for not only geriatric humeral nonunions, but I think geriatric fractures in general is not new. And so these are all pictures of cases that either I've done or been a part of in some way. And so you can see some of the challenging solutions, or some of the solutions that we found for some of these challenging issues. I think for a long time, when I was looking for some sort of way to augment my fixation, allograft cortical struts were good use here. And so for the patient on the left, the patient who had a humeral nonunion, older patient who I ended up doing a hemicortical tibial allograft strut for, and kind of shish kebabbing both ends of the bone and then overlying that with a plate for fixation. In the middle, patient who I ended up revising, who had essentially a spine cage placed in within a medullary rod for a humeral nonunion. Two other patients on the right that were patients that I took care of. One is an older patient who just had a large bony defect, and just used a large block of polymethyl methacrylate cement for an area that I thought was going to have a poor potential for healing and bone regeneration. And then on the far right, for those people who remember use of medullary plates, right? This is one of the first ways that we were able to think of supporting the medial column for distal femur fractures. It's been used in other areas such as the proximal tibia, proximal humerus, but inserting actually a medullary metallic implant to support fixation, when we needed to augment fixation. So, things that we've gotten creative, so to speak, with regard to how to support our standard plate and or nail fixation techniques. The challenges in these situations are multifold, especially in the humerus. It's a non-weight bearing bone. And so for older individuals, this bone quality is oftentimes very poor. The vast majority of standard titanium metallic medullary nails are insufficient. And because the reason being is that as that medullary canal becomes more cavernous, especially in the mid-diaphysis, even the largest humeral nails have very poor endosteal contact, especially in the mid-diaphysis. And you can imagine, the larger the nail is in the diaphysis, the larger the entry portal has to be in the proximal aspect of the humerus. And oftentimes, depending on the nail manufacturer, nails are obviously changing as time goes on, but poor torsional stability is a large amount of torsional moment on humeral fractures. And so for these implants, their fixation is really only as good as the interlocking bolts that exist proximally and distally, since we just went over the fact that they have poor diaphyseal support. And so you can imagine poor bone quality, these interlocks loosen, and oftentimes in isolation don't do very well. Multiple implant fixation is challenging, especially in the humerus. This is not the proximal tibia or the distal femur, where plate nail constructs are, I would say, a little bit less technically challenging. Dual plating is not a great option. You may be able to have orthogonal plating with a lateral plate and maybe an anterior plate as well. Plate nail constructs have been done. I've done them before. But again, as you get into the diaphysis, especially in some of these older patients, avoiding a metallic medullary implant can be very challenging. These patients in general are not ideal candidates for staged or multiple operations. They've likely, or oftentimes have just been kind of pushed along and treated in a non-surgical manner because they are an elderly patient, because they have an upper extremity non-weight bearing fracture. And so they don't want to hear about the fact that you're going to do a resection, then do an antibiotic spacer, then come back and bone graft them. And if their biology is not great, they may need a second bone grafting or similar. They're looking for the for the one and done, so to speak, to be able to initiate motion and start weight bearing, even if it's just activities of daily living at a sooner time point. And I think this is important, right? Because these patients utilize their upper extremities. They may walk with a walker. They may do ADLs either at their own home or an assisted living facility or similar. And so they desire to have motion in their shoulder and elbow, what may be left of it. Oftentimes these joints are often arthritic as well. Patients may have shoulder stiffness that's been developing over years. And so long periods of immobilization are not ideal. So for this reason, and for whatever reason, I think, over the last, handful of years, maybe just because my referral practice has continued to grow over the last 10 or so years that I've been in practice, I've seen a lot of these patients who have delayed, not delayed unions, but delayed presentation of upper extremity fractures that have gone on to non-unions. And so it's either a gross malunion or a gross non-union with motion, or it's a malaligned, incomplete union or something similar. So this is the situation where I started to use IlluminOss as a way to support the bone that I was going to be fixing, aligning, and fixing. And the reason being, again, for a lot of the challenges that we talked about here in terms of obtaining adequate fixation strength. So let's go through a couple of cases here. And then I'm going to finish off with some of the other areas that I've utilized IlluminOss in with regard to supporting fixation. So this is a 79-year-old female, fall from standing. She had an ORF 1 year ago. She had right upper extremity pain and inability to use the arm, BMI of 37. And so this may have been the first IlluminOss case that I did a handful of years ago. And so you can see the radiographs there on the left. Patient was likely well aligned, and actually the surgeon at the time used orthogonal implants, likely because of the fact that bone quality was very poor. You can see, just based on the position of the screws, utilization of locking technology, especially in that anterior plate. And so loss of fixation, even with orthogonal plating. And, I don't think I ever saw the initial radiographs, but a plate of, what I believe would be sufficient length for what I believe was a relatively transverse fracture. And so took out all of the implants, obviously, prior to this, did a workup for infection, because if I'm going to be thinking about utilizing an implant, which is going to be, in my mind, a permanent implant, want to make sure there's no concern for infection. Took everything out, took cultures, made sure that those cultures were clean intra-op, and then proceeded with fixation. You can see use of the IlluminOss device here. And so this helps me align the fracture on the AP and lateral view. And now I have a medullary implant that is not only helped me align the bone, but also provides an excellent point of fixation for my definitive implant, which will be along large fragment plate, which spans the entirety of the humerus. So from stem to stern, using a combination of locking and non-locking screws, both proximally and distally. And my final radiographs on the far right, obviously the patient needed a large incision to get out all the previous hardware. And so I utilized that exact same incision for definitive fixation. And the radiographs on the far right, I think are at 6 months. This is the last time I saw this patient. He asked me if we needed to keep coming back. He thought his arm was doing well. And I said, no, not unless you have any issues. And so that was, I think that's, like I said, I did this case a few years ago. And so some, maintenance of all implant position. Do I know, or do I believe at this radiographs on the right that the patient has gone on to complete healing? No, but patient was a relatively low demand elderly individual who just wanted a stable arm to be able to utilize. I think the other thing that's really nice about this implant is that, depending on the length of your definitive plate, span can be used to span the entirety of the femur, minimizing the chances of a stress riser. And so oftentimes we worry about where the plate may end in some of these older patients. You can see the very poor bone quality that exists the distal aspect of the humerus. And so the IlluminOss device can be positioned from the proximal humerus all the way down to the olecranon fossa distally. This is a patient who I actually just saw today in clinic. She's now 82. She just turned 82. Fall from standing. She was initially fixed in the somewhere in the Middle East, and then had failed fixation. Was then in Europe. Shortly thereafter, had a revision with this proximal humeral plate and cerclage cable, and then because of family reasons and some social situations, moved to the United States permanently. And so this is when I saw her. And again, I think it's important to note, if there's any modifiable risk factor, especially from a metabolic standpoint, this usage of this device and this technique takes away nothing from the standard workup that we'll do for infection, any sort of metabolic abnormality that may be reversible or treatable prior to surgical intervention. But again, for a lot of these patients, they're older patients. They're relatively low demand, and the thing that they really want is just a stable upper extremity to be able to do their activities of daily living and begin weight bearing. So I apologize. I don't know where the fluoros for this case went. I tried to ask Doug, my X-ray tech, to find them. Unfortunately, this was a couple of years ago, and so I wasn't able to find them. But the workflow is relatively the same. Took all the hardware out, debrided the area of around the cerclage cable, which unfortunately was largely necrotic. So you can see some of the bone gap on the radiographs. These are initial postoperative radiographs on the left-hand side, and then use the proximal humeral locking plate with the IlluminOss device here. And then actually these radiographs on the right are from today in clinic, and the patient is now I think about a year and a half, 2 years out, overall doing very well. Similarly, you see no change in the position of the plate and screw device, any of the screws that have been positioned, and the patient is overall doing well and has been weight bearing throughout. In general, I'm letting these patients do ADL weight bearing immediately, and we'll see them back 2 weeks, check their incisions, and then at about 4 or 6 weeks, let them go full weight bearing on the upper extremity, mostly just to make sure that the soft tissues and things like that heal and give a little bit of rest, because oftentimes there's a lot of dissection that goes along with taking out some of the previous implants. You'll see a couple differences between those first two cases and these two cases that I recently did within the last handful of months. And I'll, it'll be pretty evident, but I'll go through the rationale towards the end here. There's an 85-year-old female, 6 months out from fall from standing, treated in a coaptation splint and then a Sarmiento, and then just told that eventually things would heal and that she'd have function, but shoulder may not be the same as it was before. And she had gross motion at a fracture site. She's one of these people who would try to shrug her shoulders and she'd have an apex kind of lateral deformity right at the proximal third of the humeral shaft. And so I did save some fluoros for these, which I think has been helpful with regard to teaching and understanding kind of the workflow. And so aligning the fracture, right? Fracture reduction is paramount. And oftentimes, because this implant does expand within the medullary canal, utilizing either clamps or maybe a mini fragment plate or something like that to maintain reduction while the implant is placed, and then while it's inflated, so to speak, or filled with the monomer. And so here's first placement and then expansion of the implant within the medullary canal. And then the reduction that I have was a valgus, a slightly valgus reduction. You can see based on the radiograph, the fluoroscopic images here, that the humeral head was in slight valgus. And so I did modify the proximal portion of that plate to fit the valgus reduction that I had, and then used a second anterior mini fragment plate to support this. And again, this is a very powerful tool, because now I have two plates that have planar stability and this proximal humerus. You see my final radiographs there on the left-hand side, and then radiographs at last follow-up. I think these are 2 or 3 months on the far left. And so again, maintenance of implant, you can see the position of the IlluminOss implant throughout the medullary canal, and screws from both that lateral plate and the anterior plate engaging the medullary device. It's an 80-year-old female, a year out from her injury, continued to have left upper extremity pain. She was a little bit larger, but you can see the malalignment on the scapular Y view here. Looks like this patient was actually trying to heal this fracture. Has some existing arthritis in the proximal humerus as well, and so spoke to her about fixation. She just wanted something where she could use her arm and get her shoulder moving again, because her shoulder was getting quite stiff. And so very similarly, aligning the fracture. You can see my reduction here is actually in a slight amount of varus, but I had good cortical contact with this reduction. And so placement of the IlluminOss device, expansion within the medullary canal, and then placement of first an anterior mini fragment plate, which helped me hold my reduction. And this was interesting, and I think shows the power or the strength of the fixation of the screws within the IlluminOss. And so if you look at the position of the plate on the far left, that's a plate that has not been modified or changed in any way, shape, or form. There's 2 left-hand images are just showing, me balancing my plate on the AP and lateral view. And then my first screws that go in are in the metaphysis on the caudal aspect of the humeral head. And you can see that as I bring those non-locking screws down, how it actually changes slightly the position and contour of that proximal humeral locking plate, which was used in this. And so that, I thought that was, I think I recognized it initially, but I didn't see them kind of side to side until I put together this presentation and realized that those non-locking screws had such good purchase within the medullary canal and into the IlluminOss device that it actually slightly deformed the plate. And so this is excellent fixation for a patient who's 80 years old. And I think, I will accept that small amount of varus malalignment in this patient. And so these are my final radiographs. I don't know that I've seen her back yet, and so that's why I don't have anything further on this. So I'll finish up with just a couple of opportunities and locations for medullary supports. The humerus is where I've used this the vast majority of instances. And again, these humeral non-unions, something where I need to fill the medullary canal and support that with a plate is probably my primary indication. But I have explored other ways and other anatomic locations. And I think obviously if if you're using this device, if you followed its usage, if you support its use, then you've seen a lot of these other cases as well. So there's an 86-year-old female, ground level fall, had an extra articular distal humerus fracture, extra articular, and so you may just argue, hey, just leave us alone. But if you look at that far left-hand image, you can see the transposition of the humeral shaft. This was actually anterior, so the joint was posterior. She was completely translated, and so spoke to her about fixation. She was actually a relatively active 86-year-old, and so used some mini fragment plates to just maintain reduction. And then through the lateral column, it doesn't show up well, honestly, because her bone is quite poor, but you can see in that fluoroscopic image on the left, and then after final fixation here, you can see the IlluminOss device through the medullary canal into the diaphysis. And so now I had points of fixation both distally and proximally into the IlluminOss for this fracture. So came together really nice. And I actually just, those mini fragment plates were just provisional holding plates, and then they came off when my definitive small fragment periarticular locking plates were positioned. I know straight bones or curved bones, such as the medullary ramus, are prime areas for usage. I've used this a few times in the pelvis. This is a patient who's a 90-year-old female, unable to ambulate, came into us, history of multiple falls, see kind of this interesting location. She has, almost these crescent type fractures through the ilium disruption of the pelvic ring, and she was quite sickly, and her bone quality was overall quite poor. Going through her CT scans, and you can see the plane radiographs up on the top there. And so for her, utilize the supraacetabular column to go all the way from the AIIS, or just above the joint, back towards the PSIS, and supported this with the IlluminOss implants, and just let her weight bear immediately afterwards. I saw her, I think, once post-operatively, and she was back to her baseline. So again, utilization for essentially bilateral insufficiency fractures of the pelvis, which are in a little bit of an interesting location, not the usual sacral insufficiency fractures we see, or sometimes the ones that we see in the anterior portion of the pelvic ring. I think the distal femur is we've heard a lot, just in general over the last 5 to 8 to 10 years about combined implant constructs. And if you go back to, Jeff Maff's principles about, supporting the medial column, when locked implants did not exist, we talked a little bit about medullary plate placement and supporting that medial column, and doing that in a way that's biologically friendly. And I think that's one of the reasons that plate nail constructs are quite popular. And so this 90-year-old, after a ground level fall with a periprosthetic distal femur, I actually just used the standard retrograde access point through the knee for placement of this. But you can see my plate is helping to maintain my alignment, and then placement of the IlluminOss kind of centrally and up the medial aspect of the diaphysis through the metaphysis, and then utilization of that implant to support my fixation from the lateral plate. I think this patient was actually from Central California somewhere. I don't know that I ever saw her back again, but just showing these kind of in quick passing. I'll wrap up with a case which I did a couple of years ago, but was very demonstrative to me with regard to kind of the power of this device, and you'll see why. This is a 41-year-old female, so not a geriatric patient, but she has a history of osteogenesis imperfecta. She's on the larger side. She has a BMI of 52. Her baseline is in a wheelchair, but she ambulates to the walker, transfers independently. She lives with her partner at home, and she presented with this fracture. And you look on the AP and lateral view, and I'll go through some advanced imaging. You can see how the previous implant that she had for her OI kind of acted like a log splitter and split the condyles distally at her knee. There's a little bit of a treatment challenge, obviously, because of a patient's size. In a second, you'll identify the general size of her bones, which was quite a challenge. Her bones quality was quite poor, and you can see this based on the CT scan here. This is an intra-articular fracture, but her bones were, just incredibly poor quality. So there's a little bit of a challenge in terms of treatment decision, in terms of what implant I was going to use, whether I was going to remove the previous implant that was present, how I was going to address this metaphyseal comminution and this shortening. And she was a handful of days out, if not longer than that. And so she was already pretty short with regard to the metaphyseal comminution. And so I needed to address this and figure out what implant I was going to use. Fluoroscopic images here show how I address this challenge. That's a proximal humeral locking plate that I have on the two left-hand images. And so while this patient was quite large from a BMI standpoint, I first took a distal femoral locking plate and positioned this against her bone, and it looked just absolutely ridiculous. And you can see here how this proximal humeral locking plate actually looks to be appropriately sized for this patient. As I mentioned before, she was short, and so utilized the universal distractor in the femoral shaft as well as in the proximal tibia as best I could to try to help regain her length, and utilize the plate as kind of provisional fixation. But again, I'm talking about trying to use a proximal humeral locking plate to fix a distal femur fracture in a patient with a BMI of 52 who probably has poor ability to, to control weight bearing, or wants to get back to weight bearing, at least in a transfer at an earlier time point. So utilize I'll go back one. You can see the cannula or the awl on the far right-hand image there. And I'm utilizing this through a medial condylar entry point. And so fix the medial column, or try to stabilize the medial column with an IlluminOss, which is wedged up against the previous implant that she had for her OI, and then just docked as many screws, including a drill bit, into that IlluminOss and into the bone for fixation. Given the fact that there is challenges with regard to screw trajectory, you can see looks like there's something on the lateral aspect of the plate, and so I use this small wedge of polymethyl methacrylate to just try to help lock in those screws and just have them last longer than it took for the bone to heal. And so this is what I left the operating room with. My final AP and lateral images, and then this is final follow-up. So this patient is now over a year out. And you can see the robust amount of kind of posterior and medial callus, which was formed right along the IlluminOss. You can see the space that the IlluminOss occupies on the medial side. And I think, again, remarkably, if you look at the position of the implants, the screws haven't changed one bit. None of them backed out. None of them changed position. And we saw that in the distal humerus, or in the proximal humerus cases as well. And so I think that's very telling about the fixation strength that you have. Oftentimes we'll talk about use of locking technology and poor bone quality, but the interface between the bone and those locking screws are still kind of the limiting factor, right? Like the locking plate will fail, kind of in block with the locking screws all attached to the plate. It's really dependent on what kind of purchase or what kind of bone surrounds those locking screws. And so, I'll just say in conclusion, geriatric fractures in general remain a challenge. I think we're all seeing more of them. We see more of them as these patients are more active. Placement of some non-biologic medullary support or augmentation is not new. Fibula, use of fibular allografts, especially in proximal humerus fractures, is not uncommon. If you talk to people who do a lot of challenging fractures, they'll talk about some of the interesting ways that they used medullary struts for supportive fixation, as a surrogate for a metallic medullary nail where they can place their screws into. And it's really just a way to augment your traditional fixation techniques. And I think it's really valuable in cases where you need or desire immediate weight bearing and range of motion. For me, the advantages of IlluminOss and where it fits into my practice are those situations where I can have some sort of minimally invasive way to support a column that would otherwise be supported with a standard implant. In the humerus, I think it has a tremendous advantage because it can expand to fill both the entire length and the width of the medullary canal, which is very challenging for a lot of other standard implants. If you go back to one of those first cases that I showed you with the hemicortical tibial strut, that strut was placed through the non-union site. So I had to gap open the non-union site, kind of wedge it up one side, realign the bone, and then use a dental pick to kind of push it back down until it's seated into both sides. And so for the IlluminOss, the technique for insertion is familiar if you ever place a medullary nail. And I think the advantage is that it provides really excellent fixation for screws. When you're thinking about dual implant techniques, instead of having to worry about avoiding a metallic implant with your screws, you can now utilize the medullary implant for fixation of your screws. And so whether that's in the distal femur, proximal tibia, humeral shaft, as we saw before, that's really powerful. And so I think for me, that's one of the things that's been kind of a game changer in terms of managing these patients and not worrying as much about their overall poor bone quality when I apply my fixation implants. So with that, I will wrap it up. Thank you for